Okay, ladies and gentlemen, why don't we get started? My name is David Celentano. I am the Prevention Corps Director, and it is our pleasure today to host this town hall meeting for the Hopkins CFAR about the evaluation of PEPFAR that was conducted by the Institute of Medicine. One of the rules here is if you want to eat pizza, you have to sign in. So please sign in before you leave if you haven't done so today. Just for those of you who are familiar with the Center for AIDS Research, we do training, supporting, and mentoring of new investigators. We're addressing the Baltimore epidemic and strengthening our international collaborations. This is really a remarkable institution to have here at Hopkins, and we're very pleased after a hiatus of many years to have a CFAR back. Our presenters today will include the chair of the IOM PEPFAR evaluation, Bob Black, who is a professor of international health at Hopkins and former chair for the last 28 years of IH. He's a very happy man. He's a member of the IOM, obviously. He's on a number of advisory boards for WHO, International Vaccine Association, Institute, and a variety of other things. And he's really interested in vaccines, micronutrients, and effectiveness studies of public health programs. Our representative from the Office of the Global AIDS Coordinator is Amy Dubois. She's the acting director of the Office of Research and Science with OGAC. They're the people who basically administer PEPFAR. She serves as co-chair for the Economics and Finance Working Group of PEPFAR. She did medical school and residency in general surgery in Detroit. She went through the EIS. She's a graduate of the MPH program here in 2003, and a commissioned officer, as you will soon see when she stands up. I wish I didn't have to choose what I wear in the morning. A member of the IOM committee was Taha, professor in the Department of Epi. He is well known for the work that he's done on HIV prevention trials in Malawi. And he is involved with all of the DAIDS networks for HIV. And finally, one of the reviewers of the IOM report was Chris Beyrer, professor of Epi, co-director of our CFAR, and director of the Center for Public Health and Human Rights at Hopkins. So I don't want to introduce them as they come up. We'll just have each person pass on. So without further ado, I will give you to Bob Black. Since we're taping this, we're not going to be able to wander. We have to look at that camera. Bob.
I think you probably want. I don't know how you want
both of these. So I'm trying to find a place to put this. Will that work? All right, thanks, David. Pleased to be with you today and present the findings and recommendations of the committee to evaluate PEPFAR. Let me get all my... So I'm sure you know what PEPFAR is. It was authorized initially in 2003 for $15 billion and then subsequently in 2008 for $39 billion. And we're now at the end of that 5-year period, and the expectation is that there'll be continued funding of PEPFAR. All that, of course, is up to Congress. So the program that we evaluated was implemented in many countries in the world. The largest programs were in 31 countries. The evaluation actually had a charge in the congressional legislation, a little unusual in my experience, that Congress told us what to evaluate, and in fact mandated the Institute of Medicine to do this evaluation and set up the statement of task for that. And broadly, we were asked to evaluate progress of PEPFAR in meeting the prevention, care, and treatment targets, some more specific requests in regard to the effects of child effects on child health and mortality and child welfare for orphans and vulnerable children particularly, to assess how PEPFAR was addressing gender issues, assess how it was affecting health systems, and so many aspects. And I won't go through all of these in detail, but it was a quite broad statement of task. The Institute of Medicine, you may know, is an independent nonprofit organization. It's not part of government, but it does work under contract and collaboratively with government as well as foundations and other organizations to conduct studies, and it does that by convening experts and getting free labor from us. The committees are established with a rigorous attention to conflicts of interest. In fact, David was on our first phase committee and thought he had a conflict of interest. It turned out maybe he wished he had a conflict of interest with the funding that never quite materialized, but therefore he had to drop out of the committee. And we did have the two-phase process of developing a planning document for the evaluation and then actually implementing it. This is the evaluation phase, the implementation phase committee. I won't read the names, of course, but I'll pause for a moment. So you can see that it is a broad committee of 20. It is very multidisciplinary, a great deal of expertise in HIV/AIDS to the extent that people could be found who did not have conflict of interest in regard to funding from PEPFAR, but also very much experienced in international activities, whether in AIDS or other areas. The evaluation was conducted really over a quite lengthy period during this 5-year phase of PEPFAR. It was really begun about 4 years ago, and there was this planning phase where we had to actually publish a report, which actually also went through a rigorous review process, and then that went back to Congress to receive funding for the implementation phase. So this was broadly an assessment of PEPFAR's contribution to the HIV response since the inception of PEPFAR, although of course many things changed during the 10-year period or even the 4-year period at the time of our evaluation, but we were to look at the entirety of the program. Of course, focused very much on the more recent period because things that were of historical interest were noted, but if they'd already changed, we didn't have so much to say about them. But suffice to say, this was, at the time we were evaluating it, a very dynamic program with many things changing as we were trying to evaluate them. The evaluation approach was very much mixed methods, drawing on a range of data sources. We had financial data available through FY 2011. I won't go through all the details here, but program monitoring indicator data, clinical data to some extent, not as much as we wished, from the Track 1.0 implementing partners. If you recall, in the early days of PEPFAR, these were organizations, universities, and others like Elizabeth Glaser Pediatric AIDS Foundation that received substantial funding to implement programs. And they, in fact, have some of the best information on clinical outcomes. Unfortunately, we were not able to access as much as we wanted there. There was other information available from sources such as UNAIDS that we used when appropriate. A very extensive document review, and believe me, there are very extensive documents in PEPFAR with the country plans, ranging up to 1,400 pages for a given year. And so, it wasn't possible to evaluate, to assess all of the information in those documents. But when we had particular questions, we would dive in quite deeply. The primary data collection was essentially through interviews, but with rigorous qualitative methods. It's my first experience being a qualitative data collector, and I was trained and I was very compliant with the methods. But it was a quite rigorous process of documenting and coding the information that came from these semi-structured interviews. And that was interviews to almost 400 people in the countries as well as stakeholders from international organizations. I'll go through a few things about the response to the congressional charge, because that's who we were responding to. For the response in meeting the targets in prevention, care, and treatment, we said in the report that there had been remarkable progress and success with actually a target that continued to increase during the period that we were looking at. And the current target was actually, at the time of the publication of the report, 6 million. And the latest reports we had were from September 2012, when we had to go to press. And at that point, the PEPFAR initiative had supported more than 5 million individuals on treatment. So incredible progress, starting from virtually zero 10 years ago. The prevention target was harder to evaluate. The target was prevention of 12 million new infections. Essentially, we didn't do any modeling, and there was not, at the time of publication, new modeling that would say whether that had been accomplished or not. One particular aspect, though, is notable, and that is the prevention of mother-to-child transmission, in which PEPFAR had played a major role in the delivery of antiretrovirals to 750,000 HIV-positive women, with an estimated prevention of HIV infections in their newborns to about 230,000. So one very specific prevention outcome. We also looked at care. It was harder to ascertain unique individuals in care because the care services were counted, but nevertheless, I think a great number of services were provided, and the target being to provide those to 12 million individuals, including 5 million orphans and vulnerable children. At the time we assessed, it appeared that care and support was being given to, or had been given to, 15 million people, including 4.5 million orphans and vulnerable children. So quite good accomplishment, it appears, of that target. We also could conclude more broadly that PEPFAR had supported the prevention, care, and treatment services. That's pretty obvious. Ensured attention to vulnerable populations, and I think this change evolved over the 10-year period, but certainly at the time, more recent time that we were looking at, there was very specific attention to the most vulnerable populations. And there's no question that the treatment, and to some degree the prevention, saved and improved the lives of millions of people. So it was a very clear statement that this initiative provided the proof of principle that many 10 years ago doubted, that services could be effectively delivered at very large scale with the countries that had infrastructure limitations and resource limitations. But with the sizable funding and the commitment of the implementing partners, that a great deal had been accomplished, and that's an important proof of principle. We looked at the effect of PEPFAR on child health and welfare, and could say that it met many of the needs of children affected with really unprecedented attention to the OVC programs. The coverage of treatment in HIV-positive children who need to be treated was likely to be lower. We actually overall did not have a good measure of coverage. For the most part, we had numerator data of how many people were on treatment or had been treated. But with estimates of the number of children needing treatment, it appeared, although we don't have precise quantification of this, that the coverage of treatment for children was lower than that for adults. The gender specific aspects, I would say, were clear in some programs, but there had been some changes or evolution in the framing of what that meant. And actually, even by the end of our evaluation, still not very clear, clearly stated objectives and desired outcomes for the gender effects, the expected gender effects. The assessment of the effect of PEPFAR on health systems was a quite extensive one. We used the WHO, the 6 building blocks of health systems, and went through each of these specifically. There was evidence of progress in many, increased knowledge about the epidemic and the epidemiologic situation of individual countries. Strengthened health information systems, although I'll have some caveats about that later. There was a clear effort in capacity building and fostering country leadership, engaging of stakeholders, governments, and non-governmental organizations. And we're now, in the last several years, much more in a I know they're not using the word transition, but in a movement from a very much U.S.-led and with services delivered by U.S. Contracted organizations to one that's much more country-led. It's not absolute in either case, but more country-led and a more sustainable response that has more of the services integrated with the national services. And certainly at the time of this evaluation, up to the time of the evaluation, still a very large reliance on external donor funding in many of the partner countries. The findings in regard to knowledge management, I would say, were rather mixed. And in fact, this was probably the area that we were most disappointed and a bit frustrated about, because to the extent that we had to rely on information from PEPFAR for much of the tracking of indicators, we did not always have the information that we needed. And more importantly, I think, it didn't seem that they always had the information that they needed, both at global and at country levels. What was done is that systems for accountability were developed through program monitoring. And there was the change over time with different definitions of or willingness to support research or program evaluation in different aspects of PEPFAR. And so we did use information that was available and used it as well as possible. There was another aspect of the knowledge management area in which we did look at what this very large initiative had contributed to the global knowledge base. And this was another area perhaps of mixed results and a bit of disappointment that with the enormous effort and experience with the programs that were implemented, that there were areas where perhaps greater learning and contribution to the global knowledge base could have been achieved. It is recognized, of course, that in the beginning the data collection systems were designed to meet the need for rapid reporting with an intent of Congress to get treatment out, and so there's a lot of reporting of services provided. Not as much harmonization with the global indicators as one would have hoped initially, but improved over time. I think improving much more now. There was a very large burden of reporting requirements, very large number of indicators. In the end, when we tried to access these from OGAC in a time series, they said, well, a lot of them are incomplete or not high quality, and we're not able to use them very well. So in spite of the large reporting burden, I think there was still a limitation on what useful information came out of that system. And as I said, the information was largely geared at services being provided, which is important, but not sufficient, I think. And so in our planning phase, as David will remember, we painstakingly went through the impact pathways the whole way, from outputs to outcomes to impact, and what information did we need, and where were we going to get that, and how to map that across what was available. I think it's pretty safe to say almost never got to an outcome, basically because there were not denominators. There was not really an assessment of whether they were meeting the need, which requires a denominator. And so, that was a bit of frustration, frankly. And so that was part of our realization as we got into this. But then, there was also increasingly over the last several years an emphasis on some expectations of the changes in responsibilities and management of these country activities, and perhaps a greater role in the future for the U.S. of technical assistance, perhaps a greater expectation for capacity building, for system strengthening, and for a sustained response. Well, one of the difficulties is there were no clearly defined, at least in our view, indicators that were being measured of some of these, I think, very important aspects that were intended by the program, I think, in good, with good intentions, but the monitoring didn't quite match. And so again, it was really more up to us to rely on what we learned through the 400 interviews with people in countries. I didn't say before, but our committee went to 13 countries as part of the evaluation. So overall conclusions, and I'll go quickly to some recommendations. PEPFAR has clearly had a positive effect on the health and well-being of beneficiaries, on institutions, and on systems, and leading the global response to HIV. I think that's very, very clear. Even with these contributions, it is also clear that there is substantial unmet need for treatment, of course, and a greater need for prevention. So at this juncture, it was important, I think, that we send a message that at the very least we need to sustain the gains and continue to make progress in controlling the HIV epidemic. And I think the efforts are underway, of course, to assist partner countries to take more responsibility and to manage their epidemics. Quickly, some recommendations just in these 4 areas: improving implementation, strengthening systems, transitioning to a sustainable response, transforming knowledge management. We have more than this, but for this discussion, I'll try to concentrate on these. So the recommendations are that the PEPFAR initiative should continue to collaborate. This is not new, it's not something they're not doing, but continue to collaborate very, very much to help countries allocate limited resources to be strategic, targeted, coordinated, and I think, for sake of time, I won't go into the detail, but one important aspect, I think, is we felt as a committee that there was a need for even greater emphasis on the prevention of sexual transmission. There had been a quite rapid response in regard to biomedical prevention issues, circumcision, treatment as prevention. The behavioral change aspects had not been as I don't want to say successful. It's not that it was unique to PEPFAR. The field has not been as successful, of course, as one would like in behavioral prevention of sexual transmission, but it was our view that this was still a great need and a great learning opportunity. So even if we don't know exactly how to do it, there should be an agenda to learn from successes and failures in regard to behavioral transmission. So we also talked about the need to shift the focus of reporting and accountability from activities to outcomes, with more flexibility at country level to prioritize how to achieve those outcomes and to develop a program portfolio. There were a number of things that were, some of which were actually in our charge from Congress that we essentially couldn't measure. Retention and adherence for those on treatment, the coverage of testing and treatment, rates of, these are just examples, but rates of staying in school for orphans and vulnerable children, various intermediate outcomes for prevention, so not necessarily measuring HIV incidence, and objectives for the gender activities. So these are examples. There are certainly more, but just to give you a flavor for what was missing in terms of the data available at the time of the evaluation. There were recommendations in regard to investing in the long-term capacity to sustain the HIV programs and management of the epidemic, and 4 particular areas in service delivery, and then 3 in management: financial management, program management, and knowledge management. And all 4 of those we thought need support from such an initiative to strengthen the country capacity. These are areas where we know that the staff of PEPFAR are working very hard on collaborating with partner country stakeholders, and these are areas that are really part of their partnership frameworks and activities, and we just reaffirm that these are important. In the recommendations for monitoring, evaluation, and research, we had a fair amount to say, I guess a lot to say, because we thought much more could be done given the opportunities, the resources, and the needs to further develop this area. And that includes developing approaches to assess the outcomes, as I've mentioned, assess the efforts on system strengthening, capacity building, and sustainability, but also to contribute to the global knowledge base that where we think there is a need and a possible great contribution. So final conclusions. PEPFAR very clearly played a transformative role and contributed enormously to the global response to HIV. People really did describe it as a lifeline and credit PEPFAR for restoring hope at a time 10 years ago when really there was a lot of despair and political and economic disruption. In the new era, where there is, I'll use the word, transitioning from direct service delivery to perhaps some more technical assistance, more support for implementation, and facilitating the partner activities. That is affecting changes in the U.S. response. That we say this, and I understand why they don't like transition, because that sounds like graduating or sort of ending the services, and that's not the intention. I know PEPFAR, it was not the intent of our report to say that there should be very rapid movement to devolve the responsibilities or the funding to these countries in need. Many countries will continue to need very substantial support for a very long time. And I think that's recognized, it was said, and there are some countries that will be able to take up much more of their own funding and service provision rapidly, but most, I think, in the highly affected areas highly affected countries will not. And even so, as there is more movement to country ownership, there may not be the rapid progress that we saw with the initiative to date, but in the end, I think this is a necessary way to transform how the health assistance is implemented. And I think that's all, except to thank our great staff. Those of you who have worked with the Institute of Medicine know that the committee gets the credit, but the staff does the work. And the staff really is excellent. They do a lot of the report, or they do a lot of the preparations for us. So that's all. Thank you.
We're going to take questions.
Mike's a little precarious, but I think you can hear me. Good afternoon. I want to thank you all for inviting me here to join with the Hopkins CFAR on this topic, which is obviously of great interest to my office at OGAC in looking at and responding to the Institute of Medicine evaluation. I want to just very briefly provide a little bit of context about PEPFAR and research, a little bit of history, a little bit of what we're doing now that we have been doing on an ongoing basis and how we're actually thinking about responding, and then just a brief look at some of the specific recommendations, how those fit in. So PEPFAR is a science-driven program, And that really has been the case from the beginning, although it certainly has evolved over the years. And I just want to emphasize always that under Ambassador Goosby's leadership, there really is a very strong commitment to the use of evidence for setting program priorities and policies, and also making sure that there is the environment and the resources to be able to produce that evidence and move that forward. That was actually institutionalized in our 2008 reauthorization, that operational research was essential to being able to define the way that the program should be run. And so we really have a mandate out of that 2008 reauthorization. But that mandate was very clear that we were looking at research that we could translate into how we run the program. So as PEPFAR enters its second decade, it's really trying to look at now how do we define the strategies and the guidance and the processes? How do we really institutionalize this in the way we do things? Then we have to take a step back just a moment to what PEPFAR's original mandate and responsibility is. Because PEPFAR is, first of all, a humanitarian assistance program. And that means that every dollar that's spent on research is a dollar that cannot be spent on direct assistance somewhere else. So it is imperative that when we support research under PEPFAR, that it is research that we can use to produce results that support back to that mandate. We have to make sure that it meets programmatic needs, that it can be used and it's useful, that we can justify spending that dollar, because we are asked to justify the spending of that dollar to our congressional overseers and others. We need to be able to do that. So there's that yin and yang of science under PEPFAR that we work under. And it's important that we never forget that as we talk about some of the other choices that we make related to the research portfolio. So we are really working at trying to institutionalize research under PEPFAR. And that means really defining a better research strategy that defines what that research mandate is, that it sets priorities and also sets a process for setting priorities. How do you figure out what those are? How do we make sure that that's more systematized and not kind of ad hoc, that it has kind of a logic to it? That we have a defined strategy for capacity building and that that's part of what we're doing all the time with our research investments. And that we link this research strategy better than has been done in the past to a larger knowledge management process within PEPFAR, so that the evidence that's being generated is also getting out there to the right people. It's important that, again, as the program matures, that we have more standardization of mechanisms, more predictable cycles, more clear, transparent process associated with that, so that once again we can make sure that we're speaking to those priorities and doing things in that kind of an order. We are working at really trying to improve our communications and our information sharing that's back and forth with our implementers, with academia, et cetera. And one of the big parts of doing that has been beginning to formalize the role of the Scientific Advisory Board. So the SAB was started by Ambassador Goosby in 2011 as part of his desire to really strengthen the links between the PEPFAR program and a range of scientific experts. It is a federal advisory committee, so it's covered under FACA, and that means that it has some very, very strict rules. Some of them are simply that all of our documents, all of our reports, our recommendations, the minutes of our meetings, everything's on a public website, it's public access. The meetings are open to the public. You have to have a section for public comment whenever you hold them. The membership on the committee is vetted through a process at the State Department that we don't have any control over, really. And these are all to ensure that we have a transparent record of this, so that we're meeting two objectives. We are making sure that we have a forum where we're really engaging the scientific community to make PEPFAR a better, more evidence-driven program, and also to provide this transparent record to Congress and to the public about what's happening to research dollars and how those conversations are happening under PEPFAR. When we talk about research under PEPFAR, the term that we've been using in recent years has been implementation science. And I think often this complicates the discussion a lot because there's not a completely uniform definition of what this is. So implementation science for us means more, it covers a big spectrum of different kinds of methodologies. And those really go all the way down to some, what would fall under the category, I think, of program evaluation, all the way out to randomized trials and a lot of things in between. And for us, implementation science is really more about kind of having a philosophy about you find the most rigorous design you can to be able to give you this pragmatic sort of information you have to have about how should you design a program, how do you budget for it, how do you run it, how do you manage it, how do you have an intrinsic evaluation process for it, how do you do that, balancing all the things that come with rigor in terms of cost and time and expertise you need to have versus if you do things, if you do a very minimal evaluation, you get a lot less information about it. So that's kind of how we think about implementation science, is it's more of that just finding different ways that different methodologies can be targeted into that same overarching objective. We talk a lot about the questions that are really related to implementation, and we just come back to this over and over. And if we, refer back to Dr. Black's, going through sort of some of the things that in the IOM they still see as challenges for PEPFAR, you can see these come out, they fall out real nicely from these kinds of questions. It really is, we can't document better retention and treatment unless we have these kinds, we've identified what those real models are and can be able to set up those systems. Looking at some of the Institute of Medicine findings specifically, obviously all of you are quite familiar, and we just had a run through these. But I think we would certainly agree that PEPFAR provides an incredible platform, an enormous opportunity for research, and some of that is untapped. The program has made a lot of progress in doing this, but I would also say that at the beginning of PEPFAR, the mandate very clearly in the first authorization was really an emergency plan. It was really about getting services out fast. So that research portion was not a specific priority. And it's really only been now that the program is more mature that we feel like we can really start to step back and try to institutionalize some of those issues that will mean going forward we will be able to take advantage of that platform and seize those opportunities. In terms of defining allowable research activities under PEPFAR, we again go back to this perspective about if your overall mission is this humanitarian objective, then the research that's allowable is whatever is appropriate for you to get the answers you need to be able to meet that mission. And so we don't have any restrictions about methodology, and we don't really have restrictions about who can do things or study designs, but we do need to think very strategically about what is most appropriate for PEPFAR funding to try to get to these answers. And that doesn't mean that we would, it doesn't take anything off the table, but it does mean that some of those decisions are quite strategic, and sometimes even things that PEPFAR also agrees are a priority for the global evidence base might not necessarily be the best use of PEPFAR money given its relative strengths and its positioning and that larger mandate. And we agree that it's extremely important that clarification both of kind of the strategy for the evaluation end of that spectrum versus the research end of the spectrum, and really what is most appropriate to be done under PEPFAR and how that's prioritized and how that's decided, that really institutionalizing those processes is extremely important for us. Another set of recommendations were related to the priorities and the process. Here again, we are working on an overarching strategy for both evaluation and for research under PEPFAR to try to accomplish those. There will be dramatically changed guidance related to implementation science and impact evaluation and evaluation writ large in the 2014 country operational plan guidance that goes out to our country programs. And that will also reflect some of the things that will be done through more of a headquarters level in addition to the country level. So that will be coming out late this year. We are, again, institutionalizing the role of the Scientific Advisory Board. We see that as a very important forum for setting priorities, and we take very seriously that it exists in this Federal Advisory Committee, so it is a public forum on that level, in addition to having that expertise. And we think that that's important because it brings those extra voices to the table and gives that expertise really across the spectrum to the ambassador in helping to set those priorities. And then, of course, our mission teams, our partner country governments, other institutions in partner countries, and our implementing partners. These are all resources that we increasingly try to engage, again, as we institutionalize, to try to find better ways. What's the right forum? What's the best process to try to set a priority agenda, knowing that you have to bring in a lot of very diverse stakeholders? Funding mechanisms are always challenging, and this is something that this will come out in multiple areas when we talk about challenges. And we certainly agree that it is important that you have a range of funding mechanisms because they do determine a lot about who's eligible or what kind of things you can generate. And I agree that you get something very different when you have an investigator-driven research, an RFA, versus things that are more targeted. But they both also have a lot of complicating factors, some unintended consequences that come with them. So that just makes puts a lot of layers on top of making those decisions. But we are trying to, in fact, do that a bit to try to segregate out some of those different options to give that diversity of funding opportunities in the new strategy. In terms of research gaps, we would agree completely that there are some areas that do not have as strong an evidence base as, in particular, some of our biomedical interventions and our treatment programs, our clinical services, and that in particular having a stronger evidence base related to non-biomedical prevention interventions is really critical for PEPFAR and for the global response in general, to be able to understand where we should be investing and what non-biomedical interventions should really, what's critical to incorporating into your larger multidisciplinary prevention strategy writ large. Same for the health system strengthening, which has really been a stronger focus in PEPFAR too, but we still struggle, as I think across the global scientific community, I think we all struggle with ways to be able to really document impact or evaluate what's being done on that forum. So we'd agree that these are all the challenges that we're facing, and again, we look through the different institutions that we work with, the SAB and others, to try to find solutions for these together, because I think they're incredibly important. And in terms of employing appropriate methodologies and designs, again, I don't think anything is off the table. It certainly isn't in terms of those. I'd say it's a pretty fair statement that there tends to be less qualitative research out there that's funded, and I think some of this is just an evolution that still needs to happen about looking at some, not even just in qualitative, but in terms of other sampling designs and using other kinds of quasi-experimental designs in different settings, which are very important for us to all adapt to as we try to look at this implementation science idea. If your primary objective is to really be able to look at what's working and really have data that's actionable, we do have to have that kind of flexibility, and I think PEPFAR certainly embraces that, at the same time working with the same struggles that all of us have about making sure that we have rigor and making sure that we have all the flexibility and the other things that we want to have too. Country ownership is a very strong priority of the legislation in 2008, of Ambassador Gooseby, and of our administration in general. So this is something that's received a lot of emphasis in PEPFAR over the last couple of years, and we agree that it's incredibly important that we are engaging with in-country partners at the government level, but also in in-country academia, in-country non-governmental organizations, to make sure that they have access, they have a process to be able to participate in this research. That contribution is critical. We do have a fair number of capacity building activities. PEPFAR does fund into CFAR. We also fund several other initiatives related to the Fogarty Center, the Peer Network, which is implemented through the National Academy of Sciences. We've supported some fellowship programs. We have programs in country that we're starting to try to ramp up a bit for teaching impact evaluation proposal preparation on a very pragmatic level. So truly trying to work with countries to actually write some of those proposals as sort of a, if you complete the course and you satisfactorily, that your proposal kind of gets fast tracked up to OGAC right into the approval chain, to try to just to try to get that on the ground, because it does require a certain amount of capacity to do it, and we know that still in country people kind of struggle with that. And then trying to get submissions from country-based implementing partners is a real struggle, because from things as mundane as just for a local organization in a country with very minimal capacity, getting a DUNS number and registering on grants.gov can be a prohibitive obstacle, and I've seen it. So is internet bandwidth to be able to submit an electronic application. I can't tell you how many times I have personally helped FedEx something to the U.S. after pounding on to try to get permission to be able to submit a paper application for somebody who just can't get it in. And those things, that's before we ever talk about did you have a good statistician when you tried to put it together. So those are very challenging, and we are always happy to hear different suggestions about how we can try to work better together to try to work on what is certainly a goal all of us share. So our challenges, if we try to sum those up, and I hate to end on all the challenges, not, I guess we talked about the opportunities at the beginning, but having open competition is always a real desirable thing, except that the more open that competition is, the less you're able to direct things towards your priorities, and that's a balance you have to always work with. Geographic representativeness is something we increasingly struggle with, because we find that we have countries where we have very large programs that, for whatever reason, have now developed very strong research platforms. They have a strong in-country partner, or they've built a cohort there and they now have lab infrastructure and things like that. It makes them a very desirable place to do research. But at some point, do their results become less generalizable to other countries where we have to also have answers about how things are working and how we might want to do things? So there's a tension there as well. Really having strong links into programs is extremely important on a lot of fronts, but particularly for key populations, because they tend to be very context specific, of course. And this rigor versus capacity building issue about how do we decide at what point the science is good enough that it's okay, that it's not perfect because somebody's learning as they go. And that's not hard. That's not an easy decision to make either. And I think all of us struggle with that. And then finally, for us specifically at OGAC, I think to try to make sure that we have a really efficient use of our research funds, because it is all about efficiency when we're talking about funding these days. And there's efficiency that we need to tap on a lot of levels. It means that we have to be able to demonstrate that money that goes into research is going to be translated back in some way to make PEPFAR a better program. We have to be able to demonstrate that within a given research project that dollars are used well. And we have to be able to demonstrate that where we could get a good range of information to really have evidence to make programmatic decisions with 4 studies, we didn't fund 11 of them because we didn't have a system to be able to sort of sort them out. And those are questions we're increasingly being asked. They turn up in our interactions with so many sections of the government you can't even imagine. We are asked to be able to document that, so that that coordination environment and being able to balance it against some of all these other considerations we have, does make this challenging. So again, we are very excited about the partnerships that we have with organizations like CFAR, where we can have this kind of dialogue and be able to talk about ways to be able to approach this. But they're all goals which are extremely important to PEPFAR to be able to make sure that this stays a science-driven program into the future. Thank you.
Okay, so we'll give you a perspective or some comments as an evaluator. We came at the end after program or after the program has been implemented for several years. So what I will reflect on here is basically the challenges and the implications of evaluating a large program, and I will be referring to PEPFAR. So the first question one would think of is how can we evaluate such a large program, multi-country, multi-billion funding, and where is the gold standard? Compare it to what? So what level of evidence will be adequate enough and strong enough to generate a credible report? So that was not easy. So probably in this school we know this very well. So these are what we consider as rules of evidence. It ranges from the best to things that are not strong enough. So PEPFAR was not a community randomized trial. Probably within PEPFAR you could find so many observational studies, before-after designs have been done, case studies have been done. So putting all these things together, how could you generate a credible report? The first consideration was this is a retrospective evaluation. It wasn't concurrent, done at the same time when PEPFAR was ongoing. So we come at the end and we retrospectively evaluate, examine what PEPFAR has done since its inception. Another question that was debated quite extensively is what can be attributed to PEPFAR. So that was not easy. So several programs, probably rudimentary at that time, were ongoing, and governments, probably not very much, they were contributing. However, there were other programs over time that could have been difficult to attribute everything to PEPFAR. At the same time, it wouldn't, if it was great or less or whatever measurement you use, probably that would have probably also does not give enough credit to PEPFAR. So what has been adopted was the contribution. How supported activities contribute to impact, and how PEPFAR contributed in the context of other ongoing activities from bilateral, multilateral, and country investments. This approach, a very nice layout was made by the committee members. The first group, Dr. Black and Salentano, were part of this. Is this evaluation approach, program pathway, and you can see here the inputs, the activities, and then the outputs, the more immediate proximate effects, and then the outcomes. These are intermediate outcomes or effects. And then the long, what we really wanted to know with any program is the impact. And that is, for example, incidence. Have we reduced acquisition of HIV? Has we reduced, for example, morbidity and mortality? So these are distant. And with ongoing program, with ongoing PEPFAR activities, probably some of these will not be realized for some time to come. However, our evaluation is at this point. But this layout was very useful. You can see the inputs for what has been included here, the activities. So it provides a reasonable platform to start the evaluation. And then another decision that has been made by the committee is to take the empirical evidence. What has been observed without going into this exercise of modeling. And doing these modeling activities was mainly the insufficient availability of data and adequate data to construct these models. So empirical data that has been available, the observations that has been available, that is what the committee used. For that purpose also there has been the idea of what can be globally used and what has also been provided from visits and interviews in the country. So the whole of PEPFAR, that was the main purpose of evaluation. Without going into different countries or different activities, what has been achieved on prevention, treatment, care, and so forth. So the evaluation encompassed the whole of PEPFAR. Yes, there was a mix of case studies. Dr. Black mentioned that there have been visits to different countries and also interviews with different stakeholders. So that was considered by PEPFAR. The PEPFAR evaluation has been an evolving process. It started with small activities, targeted evaluations, basically evaluating small activities to provide rapid service type of answers. And then it moved into public health evaluations, and there were two public health evaluations, basically the program effectiveness, and then moved to right now to implementation science. That is implementing, translating different activities. And in this implementation science, Dr. Dubois just mentioned that included probably even clinical trials. So PEPFAR evolved during this process. And the term that the committee used to encompass all these activities is knowledge management. There is a nice definition here. I'm not an expert in knowledge management, but we thought that this will include all the aspects we wanted to consider. So the types of data that has been available, monitoring data, financial data, and Dr. Black mentioned this, extensive data actually that has been available at the country level. And specific interviews were also conducted. So the challenge with knowledge management is this need to quickly measure results of PEPFAR. So this led to limited harmonization and different activities at different country levels. The program monitoring indicators did not capture sufficient information. It was mainly focused on inputs and outputs. If you remember that framework I showed earlier. And it did not capture the results of key activities. Some of these are actually difficult to measure. If you are measuring health strengthening, that is not an activity that you would expect that it will happen very quickly. And there were missed opportunities. This was mentioned, so I will not comment on this. The implications, and this is something real. As a member of this committee, I realized actually how limited our knowledge is when we are presented with a large program like this. What we know conventionally as evaluation tools, be that in research or program level, it is rather limited. I think a wider discussion or discussion that focuses on what evaluation methods can be developed to evaluate programs like PEPFAR. PEPFAR was started as an assistant program, but ultimately we want to know if PEPFAR worked or not. Did it reduce, for example, reduce mortality, morbidity? So the outcomes are known. Right now we can say these are the outcomes, but how to get to evaluate those outcomes is not easy. So a discussion is needed to develop consensus among scientists from diverse backgrounds to develop better technology or better methodology about implementing these programs. The challenge of collecting comparable data is really, with large programs, it is a real challenge. Can we develop a plan from the beginning? It will probably not stay because things are evolving. Focus on outcomes and impact data, probably this would be reasonable, that we target specific outcomes and measure the impact. And then this demand for large data requirements should be realized and acknowledged from the beginning. And if we are not able to collect good data, probably we will not be able to generate reasonable statements about success. Realized opportunities, PEPFAR, probably this has been mentioned and acknowledged. There were opportunities that has been missed. And indeed, collaboration from the beginning would have been better. But we need to realize these opportunities from the outset. Evolving research agenda and incorporate new technologies. In the areas of prevention, treatment, things have been happening all the time. PEPFAR was trying probably to adapt to what has happened, and that is a challenge that we need to acknowledge. So I will stop here.
So first of all, I just want to say to thank the Prevention Corps for organizing this event. Really appreciate that, and I think it's really been rich and interesting already. And let me also just say, sort of in the interest of full disclosure, that I have been delighted to serve on the PEPFAR Scientific Advisory Board. I'm the co-chair of the Key Affected Populations Working Group on the SAB. And there is also another Hopkins faculty member, John Bartlett, who also serves on the committee. So, as you've heard already, research in PEPFAR has really been evolving and changed from the early years where it was really quite limited, primarily because this was an emergency response. Right? That's what the EP is for, the President's Emergency Plan, right, for AIDS relief. And so there wasn't a great deal of research built into the beginning, but it really has expanded. It's shifted over time from what were technical evaluations early on to 2 rounds of public health evaluations, and now into implementation science. And I will show you some data on sort of what the portfolio looks like in some of those areas, public health evaluations and implementation science, countries that have been funded, and also some idea about the research domains. As part of course, what we're always trying to do with CFAR is look for research opportunities for junior colleagues, right? And ourselves. So the research initiatives really have been quite a broad array. There have been implementation science research awards. We'll talk about those. There have been 2 randomized controlled trials supported or are underway of treatment as prevention in various formulations at community levels. There's implementation science for key populations, a separate initiative announced by Secretary Clinton at the AIDS conference last summer. And there have been matching funds for key population research through the CAPT, the country operating plans. The IOM evaluation, you've already heard about. I won't go into this in great detail, except to say that the focus for research in PEPFAR has really been on improving PEPFAR programs in prevention, treatment, and care. That's absolutely makes sense. It reminds one, I was reflecting and putting this talk together, I don't know how many in the room had the opportunity to hear D.A. Henderson's amazing talks about the smallpox eradication campaign. And he always talked about how research was built into that eradication effort and informed it and kept shaping it and improving the response until finally they got to eradication. And he always made the case that they would not have gotten to eradication if they had used the strategies they began with. Right? That through the process of implementation and actually trying to make it happen, questions arose, targeted research was designed to answer those questions, and then the program was reformulated around the new findings. I think that's a similar model to what we are already seeing in PEPFAR, and hopefully we're going to see more of down the road. It was to enhance monitoring and evaluation. And of course now it is also focused to a substantial degree on the blueprint goals, on the AIDS-free generation goals, which are shaping not just the PEPFAR's orientation, but also, for example, the NIH research agenda. And it was also meant to assess progress on some of the key targeted goals, like reducing perinatal infections, incident infections, morbidity and mortality, which Bob referred to. And as you heard, some of that has really been doable, and some of it has really been a challenge. Strategic information spending in PEPFAR, this is from the IOM report. It goes up through 2011, and as you can see, this comes out to a substantial investment. It's only about perhaps been something like 4% of the total pot, but remember, this is a very big pot. Right? This is an enormously large program, the largest single commitment to a disease on the part of any government in history. The public health evaluations, I think were very important, and these moved out of technical evaluation into some of the more research design approaches for studies that you all are familiar with. So, for example, it allowed expansion into quasi-experimental designs that Amy Dubois mentioned, but also, in some cases, randomization designs, modeling studies, advanced statistical techniques, and having comparison groups. So those were really changes from the technical evaluation. The second round, 2009, were the public health evaluation. These are called PHE2s. This further expanded the scope of PEPFAR evaluations to look at bigger issues in HIV, again, program impact, comparative evaluations, and to encourage some in-depth kinds of studies. And I'll show you the research portfolio for these in a moment. And the idea here was really to bridge research and practice. There were some calls for concepts, but these are really very much meant to be real-world evaluations of the program. This was the 2011 public health evaluations. As you can see, there were a number of countries that just had one of these PHEs going, Cote d'Ivoire, Malawi, several that had a fair number. Tanzania had 4, Uganda 4, Botswana, and then a couple of countries like South Africa, Zambia, and Kenya with really quite extensive public health evaluation research portfolios. So there were a number of outcomes for these, and one I think that's absolutely critical as an example is the evidence that nurses could effectively deliver treatment at scale. Now, if you think about where our field is, right, one of the most important studies in terms of treatment as prevention was just published, the TANSER study looking at KwaZulu-Natal. That actually is, in many ways, a very profound evaluation of PEPFAR, because that treatment program, which was all nurse-driven, nurse-supported, at a very basic, clinical care level, demonstrated the reduction in incidence from higher levels of treatment coverage at population levels, right? And that treatment was supported by the PEPFAR program, although the evaluation was done by the Africa Center, TANSER, and colleagues, and used some very interesting implementation science tools to do so. It had an impact on PMTCT regimens. It provided a platform on prevention and treatment in discordant couples studies. It provided platforms for microbicide evaluation, and there was a good deal of work on gender. And I'm going to actually end this with an example of some work I think that requires additional research in the gender arena. But then where we are now and looking forward is the implementation science agenda. So the implementation science approach in PEPFAR focuses again on improving program delivery, on answering questions on efficiency, effectiveness, and impact of programs. So the idea here is to do a number of different things, and some folks will be familiar that the implementation science agenda for PEPFAR was first put forward in a paper by Nancy Padian and colleagues from PEPFAR. Ambassador Gooseby, Charles Holmes, and others were on that paper. It was focused on evidence-based and informed decisions on PEPFAR programs. It was meant to align with country national research priorities, building research capacity among individuals and institutions. The implementation science agenda includes NIH, CDC, and USAID, and that certainly is a change from the early years of PEPFAR. And of course, the evaluation research priorities are now increasingly a part of the advisory body mandate for the Scientific Advisory Board. So here are the Implementation Science Awards through 2012. As you can see, it's a pretty broad portfolio, a number of countries, and a number that are PEPFAR affiliated countries, but are not in the sort of classical 15 PEPFAR core countries. So for example, Honduras is there, Thailand, Vietnam is of course a focus country in Asia. A number of research projects again in Kenya and South Africa. I think this is to some extent what you're referring to, Amy, in terms of countries that have more capacity to do research, laboratory infrastructure, data, and so forth. So what about the content? Well, the largest number of these studies were in PMTCT, so prevention of mother-to-child transmission, 23 of these, and that of course has been a core focus of PEPFAR from the start. 5 involuntary medical male circumcision. Ron and Maria in the room. We have to give them a shout out that there was indeed a focus on circumcision. Treatment as prevention, 3 studies. Improving care and treatment in the cascade. And using the cascade model is 19 of these studies. So that obviously is an organizing principle that many of us are using in thinking about implementation science. And then 24 of them, multiple health outcomes and multi-sectoral approaches. So for example, looking at HIV and TB, looking at HIV and reproductive health, family planning, and so forth. And I would just add here that 73% of these went to US-based institutions as the primary research partner with their in-country partner. So this is a substantial portfolio that has been coming to US research partners. That includes the NGO sector, but also, of course, academic institutions, US universities, and other research partners. So fairly substantial portfolio. I wanted to bring this more into a discussion phase to talk about an example of one area where there still is obviously a great deal of work to be done and where there is a clear research agenda on implementation science. So what you're looking at here is new enrollees into ARB treatment in the PEPFAR program over time. And as you can see, this program has done a much better job for women than for men. Right? That is really a challenge. And when we actually, this is an example of the qualitative data. Here's a qualitative response around this from the IOM report. Most of the people that go to health centers and access counseling and testing programs are pregnant women getting prenatal care. Men essentially do not go to health centers unless they are dying. So here are the data. This is from the CDC count of PEPFAR program data, looking again at new enrollees, men and women over time. And you see in 2005, that's 2 years into the program, about 35% male, 65% female. And if you look at that in 2011, it actually didn't budge. It's really very consistent all the way across. And overall, those numbers are very large. Those are in the hundreds of thousands that were measured here. But as you can see, for the total, it's still around 35, 65. Now, it is true that in the 15 countries or so that PEPFAR is focused on, a number of them have female predominant epidemics. Vietnam does not, most of the others do. But 35, 65 is a disproportionate underrepresentation of men in service, right? That does not reflect a proportionate burden of HIV. That reflects the problem of getting men into HIV testing and getting them into treatment. And if you look at other measures, like for example, median CD4 at initiation, it's about 70 lower for men than for women. And if you look at mortality in the first year, which really came out very clearly in the report, it's markedly higher for men. After the first year, it sort of levels out. If people stay on treatment and stay in the program, they do better. But nevertheless, this is again from the evaluation looking at loss to follow-up. And I thought it's worth pointing out that in terms of loss to follow-up over time, that red curve is men. They still also are not doing as well in terms of retention, right? And retention is a critically important part of sustaining this program and obviously sustaining the gains in reduction in viral load and transmission, as well as life expectancy that we all want to see. So this, to me, is the kind of data that immediately lays out an implementation science research agenda, right? How do you better engage men in care? How do you better keep them in care? How do you deal with this differential loss to follow-up by gender? And by the way, the curve there that is doing the best is pediatrics, which is encouraging. Once kids are in care, they stay in care, but we know that actually initiations into care are still an issue for children. So pulling that together, I think it's fair to say there is a real implementation science agenda, and I would encourage you, it is quite a report to read through the whole thing, but read through some sections of it, and you will immediately start to see where the programmatic challenges are, and those are really, in my view, the scientific questions that we need to answer using implementation science. There clearly is an agenda around retaining children in care and doing better with providing treatment for kids. I think, words of advice for those who want to get involved in this is that the critical thing is really in-country involvement with partners and collaborations there. The programs that have done well are where there is, real relationship on the ground and partnership. There are a number of folks in this room who have those long-standing relationships in PEPFAR countries. And then asking and trying to answer the research questions that are really relevant to the response and that are really relevant to these PEPFAR goals. That's absolutely critical. Your sort of own research agenda, which is, what we're encouraged to think about as we carve out our own space as investigators, is important, but it has to be in service to these larger goals, and it has to make sense in terms of the PEPFAR program. We want to ask important questions with these precious resources. We want to answer them with rigor, and we want to have them be used to try and improve the program and keep it well-funded and well-supported going forward. We have only about 10 minutes, I think, left for the panel. 5 minutes left for the panels. So should we spend that time moving furniture, or maybe we'll just start? Okay.
If people have to leave for classes or whatever, please. I know Taha is teaching, but please sign out.
So, Yuka, please.
Maybe should be more explicitly stated.
Accountability? Anybody?
Sure.
I'm just going to say one thing about the report, and that is that when we talked about the needs for monitoring, evaluation, and accountability, it was not at all limited to government partners. And in fact, the intent in the future, I believe, is that there would be multiple implementing partners, and civil society organizations would need to continue to provide services in many places. I'll just say one other thing that is related to that. We had a dissemination event at the Institute of Medicine building, and with a number of invited people from countries, and they were actually raising some conscious concerns about the devolving of more responsibility to government. So on the one hand, I think we all believe that governments do have a responsibility, but the particulars had to do with the willingness of governments to deal with disadvantaged and vulnerable populations, where the U.S. program, through PEPFAR has been able to engage through the civil society largely, or service organizations sometimes made up by these, these populations. But there were people who said my government says that's illegal. They won't deal with these populations, and there are serious issues there, and that's sort of a related thing that I wanted to bring up.
Yeah, and I think certainly from a PEPFAR perspective, we try not to use the word transition anymore, which is unfortunate because there really isn't another one. But when we when we try to when we talk about this, it looks different in different places. And so where there is a government that is very engaged, that has capacity, both financial and in transition has fiscal as well as management portions, and those don't necessarily go together. But then it is, in fact, predominantly the government, where you're talking about this. But even in those settings, a good example is South Africa, which is by far the farthest along in terms of this, because they do have the fiscal means, and they're very committed. They would like to take over completely their own program. Even there, they have a very vibrant civil society in South Africa, and so there are parts of the response that remain. No one would ever consider you wouldn't have those in the civil society component. There are other countries where civil society is nascent at best, and the government, good or bad, is the only game in town. And then PEPFAR, as a U.S. government program, we have a bilateral engagement. So the government has to be at the table, even where you have to negotiate things about, again, some of these vulnerable populations. That's something that we work very hard on, and we work, with other elements of the State Department and other parts of the government, in terms of looking at what the human rights issues are, and they're significant, related to those, and making sure that we do continue to support things outside the government to make sure that there are services for those populations where they can't be protected, unfortunately, in the public sector. But that relationship with the government, you can never completely get out of it, even in places where it's suboptimal. Yeah.
Follow up on your question, in particularly about South Africa. We talk about TB and HIV integration, and with PEPFAR funding, when we think about government responsibility, HIV and the funding that has been associated with HIV has significantly increased government capacity in that sector, whereas TB has kind of been left behind in the government sector. And if you look at the ability of those governments to really take over and manage those funds, I'm wondering if we're talking about country ownership more and more, how we're thinking differently about TB and the TB sector in the government versus HIV and the HIV sector.
Yeah, I think it's different in every country. Again, integration is something that I think most if not everyone supports in principle. Although we don't really have a lot of great data on how much benefit we get or what outcomes are really the most affected by integration. So it's a bit tricky. It sounds like it's very obvious that fully integrating PMTCT into your regular maternal child health has got to be a good thing. That just has to be. But you can't necessarily demonstrate that your PMTCT outcomes are going to be as good once you do it. So it's not as easy on the ground as it might sound. And I think that's one of the reasons that integration has moved slower than I think maybe philosophically we might think it would be good to do. TB is a little bit different than that because obviously, TB is very directly related to HIV mortality, and so it's part of still the primary goals of the program. But it is an area that has, it's a disease that has confounded us in the public health sector for quite some time, and I think PEPFAR has certainly expanded the platform from which we can respond to it, but it still remains one of the places where there's still a lot of work to be done. And I think, again, this is one of those kinds of places where generating really carefully targeted, studies to tell us what is the optimal way to get to that integration that's going to, balance those different, those competing objectives.
Well, final word, but it is 1:30 and we need to stop this portion. I'm not sure if folks can stay around. We can do it perhaps more informally. Okay, thank you all very much. you.